Respected faculty and dear delegates, it's 9 o'clock. We are going to start. Our chairpersons for the day are Dr. Y.S. Guru Prasad, who is Vice President, Central Zone, Central IP, and Dr. Vishnu Mohan, EB member from Kerala. They'll be joining shortly. We also have Dr. Ankur Jindal, who will be taking today's session. I request Dr. Pankaj to please introduce him and start the course.
Yeah. So, good morning, everybody, and good morning, all the faculty. I can see that we have Dr. Ankur Jindal already here, Dr. Pratap Patra, Dr. Neha Mehra, and Dr. Y.S. Guru Prasad, Central IAP EB member and Vice President of East Zone, and Dr. Vishnu Mohan, EB member from Kerala. So, I welcome you all on this platform. Delhi IEP has been in the forefront of academic activities, and we have been doing master classes in various specialties. We did it last years in pediatric hematology, neonatology, endocrinology, and this year we started with rheumatology. Rheumatology is a specialty which looks like little away from an office-based pediatrician, and our endeavor is not to make you rheumatologist. Our endeavor is to sensitize you to most of the issues of rheumatology so that we don't miss them in our practice or in our day-to-day working. With this endeavor, we are planning to have 12 sessions, and it's important that each session has a different issue to discuss. Today, we have a very, very important session with the Dr. Ankur Jindal. The session is going to be on juvenile systemic sclerosis and other spectrums. As we were discussing just before this, that we want to make aware a office-based pediatrician that when to suspect these disorders and where really what can be done so that they are properly diagnosed in time and referred to a pediatric rheumatologist in time. Dr. Ankur, I know him for many, many years. We have been listening to him. He's an excellent speaker. And Dr. Ajay, have you shared the screen?
I'll just share the screen. We have Dr. Shyam Meena, sir, Secretary IP Delhi, to please say a few words.
Yeah.
Hello, very good morning to all. Very warm welcome to all our chairperson, Dr. Guru Prasad sir and Vishnu Mohan sir. And welcome to Dr. Ankur for taking today's session, and welcome to all participants. Definitely today's session will contribute to a lot of the improvement of our knowledge regarding the rheumatology concerned our clinician as well as our residents. So over to you, Ajay sir.
Thank you, Dr. Meena. We welcome Dr. Ankur Jindal, sir. He is faculty at PGI Chandigarh. So there's a little problem because I'm out of station.
So we can hand over to Dr. Ankur, no problem.
Yeah, just
right, sir. Sir, can I start sharing my screen?
Yeah.
yes.
Okay. Thank you so much, Dr. Ajay, Dr. Sham, and Dr. Pankaj, and Delhi IAP in particular to give me this opportunity today to sensitize pediatricians across Delhi and I think across the country about one of the rare form of rheumatological condition, juvenile systemic scleroderma, or scleroderma group of disorders. It's extremely rare. I mean, this entity is extremely rare, and I'm not sure if you have seen or encountered a case, but I'm sure you must have come across some spectrum of this particular disorder. And as sir mentioned in his introduction, our aim is not to make you pediatric rheumatologists. Our aim is that you get sensitized to this disease, and if you happen to come across a similar case or a case like this, you never ever miss these conditions, because if you miss these disorders, the consequences or the damage are grave, and they are literally irreversible. So I'll be taking on this subject today. Nothing to disclose in relation to this talk. So this is going to be my background. Sir, I hope my voice is clear and screen is moving.
Yes, yes. Please
Right,
go
sir.
ahead.
Okay, sir. So I'll be talking about predominantly about juvenile systemic scleroderma. So systemic scleroderma or sclerosis is a similar term. I mean, they're used interchangeably. So I'll be talking about classification, clinical manifestations, and predominantly focusing on diagnosis. No talk on systemic sclerosis can be complete without talking about Nailfold capillaroscopy, its use in clinical practice. I'll briefly touch upon this aspect as well. And because one of the spectrum of scleroderma is localized scleroderma, which we also call as morphia. So I will touch briefly upon localized scleroderma as well. I'll be talking a lot of cases through my experience, and then we'll also talk about some of our published experience on this aspect. And we'll be briefly touching upon overlap syndrome as well. Although throughout my presentation in systemic scleroderma, I'll be showing you cases wherein overlap is very, very common. But in the end, I will briefly touch upon what overlap syndromes are. Through these presentations, through especially the case presentation, I'll also be touching a little bit upon management of juvenile systemic scleroderma and localized scleroderma, but that will not be the focus of presentation today. We don't want you to manage these disorders. We want you to involve pediatric rheumatologist when you encounter such cases. But it's important just to get sensitized about some aspects of management as well. We're not going to talk much about recent updates. However, we leave it to the discussion. If you're interested to ask about more recent updates about diagnosis and management, we will leave it to the end of the discussion. But this is not going to be the focus of my presentation today. So let's start with the case. So this is a 12-year-old girl who was admitted last with us in 2021. She comes from Himachal. When she came to us for the first time in 2015, she was 6 years old and she was diagnosed to have systemic scleroderma at that point of time. And I'll show you how her clinical presentation was. And now in 2021, she presented with difficulty in breathing for past 3 months. So this has been her course of illness. So she presented with skin tightness for past 8 months, difficulty in getting up, polyarthritis, dysphagia, difficulty in deglutition, and Raynaud's phenomena. This was May 2015. Now, when examined, she was found to have skin tightening over both upper extremities, which was extending beyond proximal metacarpophalangeal joints. I'll show you the pictures related to this patient and many other patients who present with similar manifestations. I'll talk about modified Rodnan skin score later on in my presentation, but this is a score that we use to classify or to grade the severity of skin tightness, especially in patients with scleroderma. So her score was very, very high at that point of time. This was 38. She was also noted to have hypopigmented macules over knuckles, and she had bilateral knee and elbow arthritis at that point of time. She was investigated and she was found to have ANA positivity, which is mixed homogeneous and nuclear. And her magnetic resonance imaging of the bilateral thighs showed non-specific myositis. She had no interstitial lung disease at that point of time, but there was evidence of dilated distal esophagus. Her echocardiography was normal at that point of time. So these are some of the things that we do at baseline in all patients. We look at their cardiac status, we look at their lung status, we look at their status of their esophagus. And I'll show you why these aspects are important in my subsequent presentation. So at that point of time, she was diagnosed to have diffuse systemic scleroderma or systemic sclerosis with a possibility of juvenile dermatomyositis overlap because she had some evidence of myositis at this point of time. So she was initiated on prednisolone, methotrexate, hydroxychloroquine, and nifedipine. Nifedipine is a drug that we use very commonly for Raynaud's phenomena in these patients. In 2017, she started having dyspnea, and she was at that point of time found to have evidence of interstitial lung disease. She was given 9 pulses of intravenous cyclophosphamide from June 2017 to 2018. She was lost to follow-up, and this is a very common issue with these chronic rheumatological illnesses. Patient get lost to follow-up. She came again in 2020 with dyspnea, and she was found to have pulmonary artery hypertension. She was initiated on mycophenolate mofetil, and because she continued to have Raynaud's phenomena and she had evidence of pulmonary artery hypertension, she was also initiated on sildenafil. again, a very common issue that we encounter with these patients, and this is something that we have to ensure every time these patients come to us, they do not comply with the treatment that we give to them. And she again was non-compliant to this treatment. This chart shows the modified Rodnan skin score that I just mentioned, which is a score which is used to classify not classify, grade the severity of the skin tightness. So it was 38 to begin with, and there was some minor variation, but it was still very, very high when she came to us. And this is a score, we call it a juvenile systemic sclerosis severity score, or J4S. I'll talk about this later. And this was also continued to be high in this patient. So this time when she came to us in 2021, so for all of those who joined late, so this patient was diagnosed to have systemic scleroderma, juvenile systemic scleroderma in 2015, developed interstitial lung disease later, was given cyclophosphamide, was lost to follow up with also loss of compliance in between. And now in 2021, she is presented with dyspnea on exertion, and she was also having intermittent dysphagia, and she also had worsening of skin tightness. And so this was very clear that her disease has progressed by this time. And she obviously had no evidence of infection. So this was not infective. This was probably related to the disease. In the other history, there was nothing significant in the birth, development, immunization was all fine, nothing significant in the family history. On the examination, you can see she is not thriving well. Her weight, height, BMI are all less. She has tachycardia, and she also has tachypnea. Now look at some of the changes that this patient had. Now on general physical examination, you can see this patient has this mask-like faces. You remember this face. If you see this face again, you should never ever miss a diagnosis of systemic scleroderma. This is a very, very characteristic face of systemic scleroderma. And, thin lips, you can see this, microstomia, very small aperture of the oral cavity. I mean, this is a face that you must remember, because this is a face of systemic scleroderma. This is sclerodactyly. You can see these fingers, the skin tightness over the fingers, they're adhered. And how do you appreciate the skin tightness? I'll show you in my subsequent slides. And this is, also there is tapering of the fingers, and you can see these hyperpigmented lesions over here. So this is a very characteristic salt and pepper kind of hyperpigmentation that you see in these patients. And she also had calcinosis over knee, right elbow, and right ankle, as you can see in some of these photographs. Now, these are usually late changes in the systemic scleroderma. It suggests that the disease has been very, very progressive. So this is how we check for skin tightness, and we grade skin tightness using modified Rodnan skin score. So there are 17 areas that we have to assess, and this is easily available on the internet as well. Each area is graded from 0 to 3 depending on the tightness of the skin. And how we assess tightness of the skin in these patients. So over here, this is a normal skin wherein you can make an easy pinch out of the skin, and you can see these very fine, very, very good wrinkles over the skin visible. Now, this is grade 1, wherein you can make a pinch, but the wrinkles are not as good as visible over here. This is grade 2 over here. We score it as 2, and you can see, although it is possible to make a pinch, but there are no wrinkles over here. And this is 3, score 3, wherein it is not possible to make a pinch of the skin. So this is how we grade the severity of the skin tightness. So this is something called as modified Rodnan skin score with a maximum value of 51, and this patient had a value of 40, which is extremely high. So in the systemic examination of this patient had tachypnea, bilateral crepitations. This patient also had hepatomegaly, possibly because of congestive heart failure. She had some evidence of proximal muscle weakness. Her cardiovascular system shows cardiomegaly and loud P2. And in the musculoskeletal examination, she had generalized contractures, sclerodactyly, as we saw in one of the photographs previously. And she had generalized restriction of her movements. So this 12-year-old girl who's come with dyspnea, who has skin tightness, she has intermittent dysphagia, she has on examination, mask-like faces, microstomia, sclerodactyly, skin tightening, calcinosis at multiple sites, hyperdynamic precordium with cardiomegaly, bilateral fine crepitations, and contractures which are generalized and leading to restriction of movement. So this is a case of juvenile systemic sclerosis with almost a spectrum of complications that you can expect in a patient with juvenile systemic sclerosis. So this patient has cardiac involvement, has lung involvement, has GI involvement, also had musculoskeletal involvement, and she also has calcinosis. She was investigated. Her platelet count was slightly high, and this is what we expect in most patients with scleroderma. The platelet count is either normal or slightly high. Slightly high ESR, neutrophilic leukocytosis. Now, this patient, because she had cardiac involvement, she had high NT-proBNP and troponin T levels. Rest of the biochemical investigations were normal, and this is what we expect in most patients with systemic scleroderma. There may be a little bit elevation of AST because of muscle involvement, but otherwise these are completely normal, and CRP was high in this patient. So we did some workup for infection and antiphospholipid antibodies, which were negative, but her ANA, which was positive even in 2015, it was positive even now. And we did immunoblot, and she was anti-SCL70 antibody positive, which is one of the specific antibody for systemic scleroderma. We will talk about these antibodies later in my presentation. She had, as I said, she had very, very severe disease. And you can see in the chest X-ray of this patient, there is cardiomegaly, of course, because she had cardiac involvement, and she had developed this very severe calcification around the neck. In the barium swallow studies, she had esophageal involvement, persistent narrowing, and dilated esophagus opposite D10. And you can see over here this very dense calcification in the neck as well. Again, NCCT neck was done, which again showed this calcification near the vertebrae. This is in the HRCT chest, showing very severe changes of interstitial lung disease. You can see over here in these photographs. And this is the ECG of this patient, which is showing changes of right ventricular hypertrophy. And echocardiography shows pulmonary artery hypertension. Her ejection fraction was very, very low. She had dilated left ventricle and severe left ventricular systolic dysfunction. She also has pericardial effusion, and there is moderate tricuspid regurgitation and mitral regurgitation. So this patient is very, very severe, with juvenile systemic sclerosis and all possibly, every possible system involvement that you can expect in these patients, except central nervous system involvement. And I mentioned during the initial part of my case presentation that we assess the severity of the systemic sclerosis disease severity is assessed by this G4S score, which has parameters for general parameters, vascular, which predominantly includes Raynaud's, skin involvement, osteoarticular involvement, muscle involvement, gastrointestinal involvement, respiratory involvement, cardiac and renal involvement, with a maximum score of 40. Now, this patient had a score of 25, which was very, very high. And this is something which we use very often in these patients to assess at the baseline. And then when we follow up these patients, we want to see if this score is improving or not. Now, this patient was initially managed with prednisolone, methotrexate in 2015. She was also given cyclophosphamide and mycophenolate mofetil. But in the recent presentation, when she had very, very severe disease, she was given rituximab as well. So coming to a discussion of juvenile systemic sclerosis, it's a rare childhood rheumatological illness characterized by fibrosis of the skin. And this fibrosis of the skin is not only localized to the skin. This can involve internal organs like blood vessels, like lungs, like heart, and this can affect gastrointestinal system as well, sometimes the neurological system as well. So this fibrosis can involve almost any part of the body. Although it's a rare disease, the prevalence, the incidence is about 0.27 cases per million children per year. Considering this, we are likely to have thousands of these cases in India, but this disease still remains highly unrecognized. There are not more than a few 100 cases that have been diagnosed so far in the entire country. So this disease still, I think, remains undiagnosed in most parts of the country. And of course, the girls, just like many other rheumatological illnesses, are more commonly affected than boys. So this is how we classify. So this is a classification criteria for juvenile systemic sclerosis, which was proposed in 2007. And believe me, there is another criteria which is likely to come up in the next 1 year, because there is a group who is already working on developing a fresh classification criteria for juvenile systemic sclerosis. So over here, we have a major criteria which is essential, the proximal skin sclerosis or induration of the skin. This is the tightening of the skin. And there are several minor criteria: cutaneous, peripheral vascular, gastrointestinal, and so on. And at least 2 of these criteria are required to classify a patient to have juvenile systemic sclerosis. There are 2 types of juvenile systemic sclerosis or systemic sclerosis, diffuse and limited. Now, over here, the terms are very important. The limited systemic sclerosis is not same as localized scleroderma or localized sclerosis. Localized sclerosis is morphia, which we'll talk about later in my presentation. So amongst the systemic sclerosis, there are 2 types, diffuse and limited. Now, this is decided by the degree of the skin involvement. In patients with limited systemic sclerosis, the skin tightness is restricted to the distal part of the digits and is not involving the trunk or the face. So it is localized only to the fingers, while in the diffuse systemic sclerosis, the skin tightness goes beyond fingers and affects hands, feet, arms, chest, back, every part of the body. Now, you may say that diffuse systemic sclerosis is probably more severe disease as compared to the limited systemic sclerosis. And limited systemic sclerosis, which was previously also called as CREST syndrome. We don't use this term very often now, but this is what we used to call it as previously. And this is a spectrum which is less commonly seen in children as compared to adults. In adults, diffuse and limited forms of systemic sclerosis are seen in about 50% of the patients, while limited forms of systemic sclerosis in children are, not that commonly seen. So how do these patients present? And you can see all the panel of these photographs. The 2 most common presentation in these patients are Raynaud phenomena and skin tightness, as you can see in this patient. And again, remember this face. If you see this face with mask-like faces, this microstomia, thin lips, this is a characteristic face of systemic sclerosis. Now, these patients present with Raynaud's phenomena like this, as you can see in this photograph. Over here, you can see Raynaud's phenomena. Sometimes this can be exaggerated and they can present with gangrene. If you happen to do the X-ray of hands, you can see the loss of distal digits as well. And you can see the skin tightness and the sclerodactyly as over here. And some of these, Raynaud's phenomena, if not treated well in time, can progress to have these digital tip infarcts, as you can see in this photograph. So there is a phase of skin involvement. It starts with edema leading to sclerosis, atrophy, telangiectasia, calcinosis. Calcinosis is the late advanced stage. It's very difficult to identify this disease in the phase when the edema is starting. So most of these patients get diagnosed when there is sclerosis, atrophy, or telangiectasia and calcinosis. So let's talk a little bit about Raynaud's phenomena. So it's about, Raynaud's phenomena is very common presentation in children with juvenile systemic sclerosis, more than 90% of these cases, and often the first manifestation of the disease. Now, when a patient with Raynaud's phenomena comes to you, the question that comes to your mind is whether this is primary Raynaud's phenomena or secondary Raynaud's phenomena. This differentiation is extremely important. In children, primary Raynaud's phenomena is not as common as it is seen in adult, but of course, if you see a patient with or a child with Raynaud's phenomena, you have to differentiate whether it is primary or secondary. So what are the points? Primary Raynaud's phenomena typically begins in adolescence and more common in adults, but secondary Raynaud's phenomena, it depends on the underlying disease. It can present at any age. Primary Raynaud would typically be symmetric. While if you have seen those photographs that I showed you in previous slide, most of these Raynauds were asymmetric. I can show you those photographs again. You can see these Raynaud's phenomena are asymmetric. Some fingers are affected, some are not affected. So that's how the secondary Raynaud's phenomena typically presents. Primary Raynaud will not lead to tissue necrosis and gangrene, while as you saw in the previous photograph, necrosis and gangrene may be present in secondary Raynauds. And if it is present, this is a very, very characteristic clinical manifestation. In primary Raynaud, there will not be any evidence of underlying rheumatic disease, while in secondary Raynaud, there will be some evidence of other rheumatological disease. Could be lupus, could be scleroderma, could be dermatomyositis. So many of, some of the symptoms related to these disease may be present. What is very important over here is, and this is a standard recommendation now, that if you have a patient with primary Raynaud's phenomena who does not have any systemic symptoms, and you want to know whether this patient is primary or secondary, other than looking at these clinical manifestations, it is extremely important that a Nailfold capillaroscopy examination is done in these patients. And I'll talk about Nailfold capillaries in my presentation briefly. So this is something which must be done in all patients who are presenting with a Raynaud's phenomena to differentiate whether it is primary or secondary, because in secondary you will have nail fold capillary changes, while in primary Raynaud's phenomena you will not have any capillary changes. So this is how Raynaud's phenomena present. Typically presents with blanching, as you can see over here, followed by cyanosis, as you can see over here, and subsequently erythema. Now, all these three phases are not seen in all patients. Patient will either have one or two of these three manifestations only. All three manifestations of typical Raynaud's phenomena are not usually seen in all patients. The other clinical manifestation in systemic scleroderma include musculoskeletal disease, which could be arthralgia or arthritis. Now, this is something which is very, very common in children as compared to the adults. Gastrointestinal disease, we briefly talked about when I showed you the case. It's seen in about 70 to 90% of the cases. It can involve the entire GI tract, but typically starts with esophagus and then go on to involve the other parts of the GI system as well. Cardiac disease is more common in adults, and it can present as pericardial effusion. It can present as conduction abnormalities. It can present as myocardial fibrosis and low ejection fraction and heart failure as well. Pulmonary disease is again more common in adults, but also seen commonly in children as well, and is one of the most common cause of morbidity and mortality in these patients. And it's very important that we do CT chest at the baseline and repeat it every 2 to 3 years. And also look at the pulmonary function test in these patients if there is any evidence of interstitial lung, restrictive lung disease. And this is something which mandates a hiking in the therapy of systemic scleroderma. Renal disease is extremely rare in children, but it can present as scleroderma renal crisis. But in children, we haven't seen any case of renal disease. Central nervous system disease, again, is very, very rare and can present sometime with cranial nerve involvement. This we have already talked about, juvenile systemic sclerosis severity score. We call it as J4S. This is something which is helpful at baseline. And then as we follow up these patients, we want to know if the disease is improving or it is worsening. And this also we have briefly touched upon as when I presented the case. Most of these patients have anemia, leukocytosis, eosinophilia in about 15% of the patient. ANA is frequently seen in these patients, and many of these patients have anti-SCL70, also known as anti-topoisomerase autoantibody. So this is one of our published experience. We published about 40 patients, and out of these, 22 had overlap with either SLE, juvenile dermatomyositis, arthritis, or polymyositis. And this is a comparison between patient with pure systemic scleroderma and patient with systemic scleroderma with overlap. Cutaneous ulcers are seen more commonly when it is just pure scleroderma. Myositis is more common when there is overlap, and use of steroid is much more common when there is overlap. And methotrexate again more commonly used in overlap group, and hydroxychloroquine also more commonly used in overlap group, and cyclophosphamide on the other hand more commonly used in pure systemic scleroderma group. Mortality, however, there is no difference, and this plot also shows that there is no significant difference in the survival between patients who had scleroderma, pure scleroderma with or without overlap, and if they have interstitial lung disease or no interstitial lung disease. So there are 3 published series on systemic scleroderma from juvenile systemic scleroderma from India. So this is one from SGPJ Chandigarh. This is from All India Institute of Medical Sciences, New Delhi. And this is the study that we published on about 40 patients. And this is, these are the results of, these studies. As I said, arthritis was more commonly seen in children as compared to adults. This is a very universal finding. And we lost 6 out of these 40 patients because of infection or because of the disease. As I said, no discussion on systemic scleroderma can be complete without having a brief discussion about Nailfold capillaroscopy. This is a tool which is most often used in patients with the systemic scleroderma. The only definite indication of use of Nailfold capillaroscopy is to differentiate between primary and secondary Raynaud phenomena, but it is also very, very helpful in follow-up of patient with systemic scleroderma. So Nailfold capillaroscopy is a technique that visualizes the nailfold capillary. So you see the nail fold, capillaries through Nailfold capillaroscopy. And this is how a typical Nailfold capillary would look like, an inverted U-shape pattern. So these are the devices that are used. So this is a device which is the gold standard, and this is the device that we use in PGI Chandigarh. Now this is a dermoscope, which dermatologists very often use, and this is also known as dynolite. This is a specific instrument for assessment of nail fold capillaries. So we use this. However, dermatologists often use either dermoscope or a dynolite machine to assess nail fold capillaries. And these are the parameters that we look at. So we look at the capillary organization, architecture, morphology. We look at the number of capillaries present in one particular area. We also look at the capillary size. We look at if there are microhemorrhages, if there are any avascular areas or new angiogenesis present. And these are these typical scleroderma patterns. So you can see these capillary abnormalities. Now this capillary is more or less okay. You can see these dilated capillaries. These are giant capillaries present over here, and this is complete disorganization of the capillary structure over here. So some of the patients, as we saw, this patient is a case of juvenile systemic scleroderma, also has these distal tip ulcers and infarcts. You can see this is the nail fold capillary pattern visible using dermoscopy, and this is the nail fold capillaroscopy pattern visible using nail fold video capillaroscope, which is the standard. And you can see these hugely dilated capillaries. Over here also you can see, over here also, with the help of dermoscope also, you can make out that some of the capillaries are very dilated. So another patient, this is another patient with the juvenile systemic sclerosis. You can see this dilated capillaries over here. You can see these hugely dilated capillaries over here. This is a capillary, this is a microhemorrhage. You can see these giant capillaries over here. And many of these photographs shows these nail fold capillary abnormalities in patients with systemic scleroderma. So this is a tool which must be utilized very often whenever you encounter a patient with Raynaud's phenomena. And of course, if you have a patient with systemic scleroderma, it is very important that we follow up these patients with nail fold capillaroscopy. If we compare the systemic scleroderma in children and adults, systemic scleroderma in adults is, of course, much more severe. We see arthritis and muscle inflammation more common in children as compared to adults, while adults have a lot of interstitial lung disease, gastroesophageal dysmotility, renal involvement, arterial hypertension. Raynaud phenomena is more common in adults, and limited cutaneous forms of systemic sclerosis, as I mentioned, is more common in adults as compared to children. Briefly touching about the autoantibodies, because you get to do ANA in these patients, and then you get to do immunoblot in these patients. Now, a lot of autoantibodies are seen in patients with systemic sclerosis, and there are plenty of them, but the three which are very common and which are specific only for systemic scleroderma are anti-topoisomerase 1, anti-centromere, and anti-RNA polymerase 3. This anti-RNA polymerase 3 is typically seen in adults because this is associated with renal crisis. We very commonly see anti-topoisomerase 1, which is also known as anti-SCL70, and this is something which is also associated with interstitial lung disease. Anti-centromere antibody, on the other hand, is typically associated with limited form of systemic sclerosis, which, as I said, is more common in adults as compared to children. So this is the autoantibody profiling in systemic sclerosis using a systemic scleroderma specific immunoblot that we do in PGI Chandigarh. And this is our experience with 43 patients in whom we have already done this immunoblot. And as you can see over here, anti-topoisomerase 1, also known as anti-SCL70, is the most common antibody in about 30% of these patients. Almost 100% patient had autoantibody positivity. And what is very important is that 12 patients were found to have multiple autoantibody positivity ranging from 2 to 4. So this is how the autoantibody profile looks like. There is some correlation between presence of these autoantibodies and the clinical manifestation. As I said, anti-topoisomerase 1 or anti-SCL70 is associated with interstitial lung disease, while presence of anti-RNA polymerase 3 is associated with presence of renal disease. I'll show you some more cases. This is a 16-year-old girl who's come to us from Punjab. She is presented with tightness of skin and bluish discoloration of fingers. So this is, Raynaud's phenomena and tightness of the skin. She presented with these manifestations. She was found to have ANA positivity. Nail fold capillaroscopy was abnormal. She was found to have modified Rodnan skin score of 32, but no other internal organ involvement. She was initiated on methotrexate, nifedipine. Her scores improved, but she was found to have some difficulty in deglutition. Now, if you have a patient with systemic scleroderma who has difficulty in deglutition, and if this patient is taking calcium channel blocker, the first thing that you have to do is stop calcium channel blocker because they cause a lot of gastroesophageal reflux in these patients. Now we stopped nifedipine. We started this patient on sildenafil. Her skin tightness continued to improve, and she had no new complaints so far. So this is how she looks like, much better than the cases that I showed you previously. And on systemic scleroderma specific blot that we did, she was found to have acute autoantibody positivity isolated. Her Nailfold capillaries, which were very abnormal to begin with, they improved on follow-up. So this is a slightly milder form of juvenile systemic sclerosis. And this is some association of anti-Q antibody with ILD, but also associated with this predominantly a milder phenotype. Another case is a 14-year-old girl. She presented with Raynaud's, pigmentation, ulceration, tightness of fingers and face. You can see over here, she's ANA positive with a modified rodent skin score of 22. To begin with, there was some interstitial lung disease. That's why she was initiated on mycophenolate mofetil. And then she went on to have some changes in the heart, although there was no myocardial fibrosis, but she was noted to have ventricular premature contractions. A Holter was done, which showed single ventricular ectopy, although this required just beta blocker and nothing else. So she was initiated on metoprolol. She was continued on mycophenolate mofetil. Her skin tightness got better, and now she has a modified rodent skin score of just 2. She has no cardiac symptoms and continued to have Raynaud's phenomena, and she's been initiated on sildenafil. So this is how she looks like. She still has Raynaud's phenomena and these digital tip gangrene. Her Nailfold capillaroscopy has got slightly better, and she is SCL70 or anti-topoisomerase autoantibody positive. And this is her ECG showing ventricular premature contractions. Another case, a 13-year-old girl, tightness of skin and Raynaud's phenomena. You can see the course of this patient, very similar. She was very long-term follow-up, 2005 to 2011. She was given methotrexate, which was stopped. She continued to have a little bit of skin tightness, some dyspnea. However, her HRCT was normal, so she was not initiated on any treatment. At this point of time, she is not on any treatment. This is how her hands look like. There is some degree of skin tightness, but she doesn't have any internal organ system involvement, and at present she is not taking any form of treatment. Her ANA immunoblots shows PMSCL 100 3+. Now I'll be talking about juvenile localized scleroderma later in my presentation, but over here we have seen a couple of cases with systemic scleroderma, as you can see in these photographs, as well as overlap with localized scleroderma in the same patient. You can see lesions of localized scleroderma in this patient. So this is a patient with systemic scleroderma and localized scleroderma as well. Another case, systemic scleroderma, very typical distal tip infarcts over here, and changes of localized scleroderma in this limb, as you can see over here. So if we talk about the management, I'll not go into detail, but management of this particular disease is very, very complex. It includes pharmacotherapy, some non-pharmacotherapy measures, and also the management differs based on the system involved. So general supportive measures are extremely important. So avoidance of cold, avoidance of sun exposure, general skincare, dental hygiene. Education is extremely important. As I said, loss of compliance is a big, big, big issue in these patients. We encourage them to be as much physically active as possible. And there are certain guidelines. The key recommendation is to use steroids along with methotrexate, sometime mycophenolate mofetil if they are not responding to methotrexate. If there is any cardiac and or pulmonary involvement, we tend to use cyclophosphamide in these patients. There are some literature on use of biologics. So tocilizumab and rituximab are the two common biologics used in these patients, but they are to be used very, very carefully only in patients who are not showing any response to any other form of treatment. So this is about juvenile systemic sclerosis. It's a rare condition. Overlap is common with dermatomyositis, SLE, and JIA. Systemic scleroderma blot autoantibody profile is extremely important in prognostication, and in some cases you can use tocilizumab and rituximab. I'll briefly, quickly run through some of my slides on juvenile localized scleroderma. Now, this is a different spectrum of scleroderma in children. It is not systemic; it is localized, and this has been classified as circumscribed morphia, linear scleroderma, which is the most common one, generalized morphia, pansclerotic morphia, and mixed morphia. I'll show you some of the pictures related to all of these. Now, if you see a condition like this, over here, I'll show you this particular photograph. So this is a classical example of circumscribed morphia over the chest. This particular lesion This is a lesion of linear scleroderma extending over the wrist joint. This is a linear scleroderma extending from thigh down to the leg and also going up to the ankle. Sorry. So these are the classical example of linear scleroderma. Now, this is a linear scleroderma over the face. It is called as peri-rhombic syndrome. This leads to hemifacial atrophy. Now, if you see a picture like this, you should not confuse with anything else. This is a peri-rhombic syndrome. This is a patient with another linear scleroderma starting from forehead, extending onto the scalp. This is ANKUR D-Saber lesion. And this is a patient with pan-sclerotic morphea. This is a very young child, around 3-year-old, who has this very, very severe pan-sclerotic morphea going deep down into the bone. So circumscribed morphea presents like a plaque, and some of these photographs, they can, in the very active stage, they can look like these erythema central waxy appearance. So this is more active lesion, while the lesions that I showed you, these ones are, more chronic or inactive lesions. Linear scleroderma, as I said, is the most common form of localized scleroderma, and these lesions can look like this. They can extend over the joints, can lead to deformity in the joints, and these, can lead to contractures in the fingers if they extend across the hands as well. Some of the specific forms of localized scleroderma are ANKUR D-Saber. As you can see, this lesion over forehead, extending onto the scalp, and this is a classical example of peri-rhombic syndrome, which could be as mild as this, as is seen in this patient, and it can lead to complete hemifacial atrophy, as is seen in this particular patient. Some of the other changes, lesions of linear scleroderma, they are more late stages, and you can see they can lead to atrophy and shortening of the limbs as well. And these are more photographs of pan-sclerotic morphea, can be very, very disabling in some patient. Generalized morphea, we say when there are more than four or more than four lesions with individual lesion more than 3 centimeters, at least involving at least 2 of the 7 sites. So this is what is called as generalized morphea. Mixed morphea, we say when there are 2 different subtypes of morphea present in a given patient. So I think I'll skip some of these slides because of the lack of time. So we will briefly touch upon the extracutaneous manifestation. Unlike local systemic sclerosis, which we just talked about, localized scleroderma is not so often associated with extracutaneous manifestation. Now, they can be associated with musculoskeletal manifestation, but they are not as common as is seen in a patient with systemic scleroderma. So they can present with arthritis or arthralgia, but most often because of the lesion extending across the joint, they present with deformities. Now, neurological manifestation are more commonly seen in patients with ANKUR D-Saber kind of lesion, wherein the lesion is extending from forehead to the scalp, and it is believed that this particular lesion also extends deep into the brain and can present with seizures and can present with plenty of neurological manifestations. As you can see, a lot of these hyperintense lesions presenting with seizures, cognitive decline at times. Again, a lesion over here presenting with seizures. So ocular manifestations, again, are more common in patients who are presenting with lesions over facial area. They can present as uveitis. They can present as, as in this patient, oculomotor deficits. Now, these patients, especially if the lesions are involving the ocular area, they can present with a lot of dental malformations as well. The other systemic manifestations are not as commonly seen as is seen in a systemic form of scleroderma. They are very occasionally seen in patients with localized scleroderma. So 2 more slides before I finish. So overlap syndromes, we have already touched upon some parts of overlap syndrome in my presentation when I was talking about systemic scleroderma, which is very, very commonly associated with overlap with systemic lupus, dermatomyositis, and arthritis as well. So overlap syndromes, by definition, are the inflammatory rheumatic condition in which patients have clinical manifestations suggestive of multiple distinct rheumatic diseases. So if they have overlap, they have manifestations suggestive of systemic lupus erythematosus and manifestations suggestive of systemic scleroderma. We call it as overlap of systemic scleroderma and systemic lupus erythematosus. So the diseases which are most commonly involved in overlap syndromes are arthritis, lupus, scleroderma, and myositis. The most well-characterized overlap syndrome is mixed connective tissue disease, which is defined by anti-U1 RNP antibody positivity, along with features of at least 2 of these 4 conditions that we just mentioned. There is another very well-known overlap syndrome is lupus. We call it as lupus when there is rheumatoid factor positive juvenile idiopathic arthritis. and manifestations of systemic lupus erythematosus. Now, what happens with these overlap syndrome is, you may have a manifestation of one particular disease at one point of time. And as you follow up these patients may show you manifestation of any other disease. Sometime, the manifestation of 2 or 3 diseases can be present at one particular point of time as well. But the management of these cases depend on which manifestation is more obvious. So if the patient has more severe manifestation of dermatomyositis, the management is according to the management of dermatomyositis. If the patient has more severe manifestations of systemic scleroderma, the management is according to the manifestations of systemic scleroderma only. Now, this is one publication from mixed connective tissue disease in India. This was a multi-center study published last year. And in this, there were 31 juvenile mixed connective tissue disease patients which were reported. All of them were U1 RNP positive. Arthritis was seen in large proportion of patients. A lot of these patients have overlap of scleroderma, lupus, malar rash, sclerodactyly, alopecia, oral ulcers, and a lot of these patients, 22% patient had interstitial lung disease. So with this, I wish to end my presentation over here, and I just wish to acknowledge the Department of Health Research, Ministry of Health and Family Welfare, Government of India, who funded one of our research project on systemic sclerosis. And some of the work that we have been able to do is because of the funding and, by, the student who has done most of the work on systemic scleroderma in our center is Dr. Sanmitra, and she has done the autoantibody profiling and is also carrying out genetic studies in these patients. So with this, I wish to thank, and we'll be happy to take any questions.
Thank you, Dr. Ankur. I'm sure the people who are attending must be mesmerized by the collection of patients and the pictures and the features which you showed. Many of us, including myself, have not seen these patients in practice. But yes, it's important that if it comes across, we are able to diagnose and then refer to a right person in time. We have Dr. Anu Maheshwari. She is the coordinator of this program, and she has been instrumental in making all of us design this program. And I request Dr. Manu to start the proceeding, to say a few words, and then to take up the questions and start the discussion on scleroderma and the overlap syndromes. Over to Dr. Anu.
Good morning, Pankaj sir. Good morning, Dr. Ankur. I joined a little late because I'm having a little fever. But Ankur, as usual, your talk is excellent. I mean, it's just too good. I mean, no matter how many times I've heard you speak, you always surprise us. And Ankur, there's one question which has been posted. Patient with myalgia and severe pain in the feet area, unable to walk, and also associated with some urticaria like lesions. No itching, ESR TLC high, duration of illness is around 2 weeks. The ANA is showing nucleolar pattern 3 plus, anti dsDNA is reported as borderline. Echo and chest x-ray are normal. I'm assuming this NL is normal. Can we stop investigation here considering this child as SSLE? As SLE. Okay, as SLE.
Okay, well, thank you so much, ma'am. I think this is a difficult case, and
Yeah.
it may not be possible to give a firm opinion, but one thing which is very, very definite in this case, we cannot stop over here. I mean, this patient definitely needs more investigation. Why I'm saying this? Because this patient has some objective evidence of something going on. This patient
Yes.
has a rash, which appears as urticaria, but it is not associated with itching. It could be urticarial vasculitis. I'm not sure. I mean, this is something that we have to look. This patient has shown definite evidence of ANA positivity and a nucleolar pattern. Now, if you see a patient with ANA positivity, which is very mild speckled pattern, this is something which we can still ignore. But ANA, which is nucleolar pattern, I'm not sure about the intensity of this nucleolar pattern of ANA, but if it is something like 3 plus to 4 plus, this is something that we can never ignore. So this patient definitely needs more investigation, would need a skin biopsy if this rash is persistent. just not dsDNA, this patient also needs an immunoblot to see what all other antibodies are positive. Now, nucleolar pattern, although I said nucleolar positivity in many of my cases with the systemic scleroderma, but nucleolar pattern can, although it is very, very specific for systemic scleroderma, can also be seen in some patients with lupus as well. So it is not 100% specific for scleroderma, although it is very, very specific. But, considering that this patient does not have any obvious manifestations of systemic scleroderma, I cannot say that this patient has scleroderma, but this patient definitely needs more investigation because there is something wrong going on in this patient.
Moreover, Dr. Ankur, I think the history is very short, only 2 weeks. And these illnesses tend to evolve over time.
Yeah.
So we will have to keep this patient under follow-up and probably
Yes.
treat as you go.
Yes. Sure,
Yeah.
ma'am. Definitely.
Next
Definitely.
question, Dr. Ankur.
Yes,
Sir,
ma'am.
please please comment on ASCT in juvenile scleroderma and also on key difference in prognosis of juvenile scleroderma versus adult scleroderma.
Ma'am, I did not get the term ASCT.
I am assuming it might be allogenic bone marrow maybe stem cell transplantation.
Okay. Right.
Yeah.
Okay. It's I mean, I on purpose did not touch upon the management aspect of this particular disease, which is
Yeah.
very, very complex. I mean, I have been very, very satisfying in management of many rheumatological conditions. My patients have also been very, very satisfied with the management. But the one condition where I am not satisfied, and most of my patients are not very satisfied, and that's, I think, the situation everywhere in the world, is
Absolutely.
systemic scleroderma. I mean, this is such a complex disease to manage. Now, coming to the question of autologous stem cell transplant, this is an upcoming treatment in many parts of the world. In children over here in India, we have not done autologous stem cell transplant in any of the patient or allogenic or autologous, stem cell transplant in any of our patient. But I am aware of some literature from Italy and some literature from, some other countries in Europe, wherein this is a treatment which is not recommended, but which is being used for many patients with refractory interstitial lung disease in patients with systemic scleroderma. And I mean, there are variable results, but this is something which can be used as a desperate measure in patients who are not responding. And the other question was, ma'am, what was the other question, ma'am, that you asked?
Difference between adult
Okay.
and
Yeah.
juvenile.
Right, ma'am. So we talked about this briefly in one of my slides. So
Yes.
patients with, children with the systemic scleroderma present more with arthritis, but adults, on the other hand, has more interstitial lung disease. They have more cardiac involvement. They have lot of limited forms of systemic scleroderma, which is, the skin tightness localized only to fingers and not extending, which we previously called as CREST syndrome. The prognosis is much worse in adults because they have a lot of interstitial lung disease. Yeah, these are some of the points, which are differentiating between juvenile and adult systemic scleroderma.
Dr. Ankur, you rightly said that we are usually not satisfied with the outcome. They're very, very difficult to treat, and often, you also know we keep taking your help, and it's most of the time it helps to discuss these patients because one doctor may have a different perspective from the next. So we should keep working towards treating these patients in the best possible manner. Ankur, there's one more question.
Yes, ma'am.
Is it right to start steroids for the above patient with this much investigation alone? I think she's talking about the same case,
Yeah,
2 weeks and that
urticaria.
pattern. How long can we wait before starting the drug therapy?
Right, ma'am. So, one of the, this is a common challenge that we face. I mean, unless we are sure of the diagnosis, it's very, very difficult to initiate steroids. I mean, that is a challenge that bedside challenge that we often face day in and day out. I would suggest in this particular case, if there is no obvious infection, if they've ruled out an infection, by looking at chest X-ray, echocardiography, blood culture, urine culture, then And if these rashes are persisting, and if they are not, of course, responding to antihistamine, because there was some suspicion of urticaria, as was mentioned, I mean, there may not be any harm in initiating corticosteroid for this particular patient and give it for about 2 weeks and then taper off. I would not be very confident in initiating any other drug other than corticosteroid in this patient.
Absolutely.
I think this patient needs to be investigated. If we know a diagnosis, if we know this is lupus, then probably azathioprine. And if we know if there is anything else, like for example, arterial vasculitis, this may just respond to corticosteroid and may not require any other form of treatment.
Absolutely, Dr. Ankur. One more thing she's asking is that do we do a bone marrow before starting long-term corticosteroid therapy?
Okay, so that is also a very important question. I mean, not in all patients. If we know that this patient is definite lupus, I will not do a bone marrow before starting steroid.
Absolutely.
If I know this is definite systemic scleroderma, if I know this is definite hinox colon purpura, if this is definite juvenile dermatomyositis, I will not start bone marrow. I will not do a bone marrow before starting steroid. But yes, whenever there is doubt, for example, in most patients with systemic juvenile idiopathic arthritis, we will end up doing a bone marrow before we start corticosteroid. If I see a patient with any of these conditions, wherein there is some unusual manifestation. For example, there is a lot of bone pain. There is cytopenia, which I can't explain, for example, in dermatomyositis, in systemic scleroderma. If there is a lot of lymphoproliferation, hepatosplenomegaly, which I can't explain, I will always do a bone marrow before starting steroids. So it's on a case-to-case basis that you have to decide.
Absolutely, Dr. Ankur. Bone marrow, we also end up doing a lot of bone marrows for a systemic juvenile idiopathic cases.
Yes, ma'am.
Where we are not able to, where the platelet counts are slightly low, the history is very short. So it's always prudent to do a marrow to rule out hematological malignancies. And you and I and other people have also seen such cases that they turn out to be leukemia.
Yes.
Right.
Mhm.
And any other question? Dr. Ankur, I have a question. I
Yes, ma'am.
think we're done with the Q&A. What would be the indication in juvenile scleroderma patient where you would upfront decide, no, this patient is going to be bad and I need to give drugs like cyclophosphamide in these patients? Because most of these are young children who, are going to live with this disease. Probably they're not going to get cured. So, deciding about what is the appropriate immunosuppression is a very difficult decision. And I would like to say, what about cyclophosphamide? When would you decide, okay, this patient, I need to give upfront cyclo?
Right, ma'am. So we use cyclophosphamide in patients with systemic scleroderma whenever there is an evidence of interstitial lung disease. Sometimes that evidence of interstitial lung disease is very, very mild. They are not symptomatic, and even when you do a CT chest, a radiologist report, there are very, very mild changes of interstitial lung disease, and the pulmonary function test is near normal. I mean, these are some of the cases where we can still think of taking a chance and initiate on mycophenolate mofetil. Now, if you compare this from adults, now for adults, the first treatment of choice for interstitial lung disease is mycophenolate mofetil. But for us, we always initiate them on interstitial cyclophosphamide whenever we see interstitial lung disease, if the changes are a little more significant. The other indication for cyclophosphamide is any other major organ involvement. For example, if this patient has cardiac involvement, if this patient has any form of neurological involvement, if this patient has very severe GI involvement, which we don't see very, very often in juvenile forms of systemic sclerosis. But yes, for us, the indication to start, most often indication to start cyclophosphamide is interstitial lung disease. Now, if a patient doesn't have interstitial lung disease at presentation, there are not very strong prognostic biomarkers to say that this patient will progress to have interstitial lung disease. Although presence of anti-SCL70 antibody or anti-tocoisomerase antibody suggests that there is a high risk of interstitial lung disease, but we have seen patients with anti-SCL70 positivity that some of these patients do not progress to interstitial lung disease. So just presence of autoantibody positivity does not mean that we will escalate our treatment. But yes, if there are any such organ manifestations, we will upfront escalate our treatment and give cyclophosphamide.
Dr. Pratap sir is here. Dr. Pratap sir, would you like to ask Dr. Ankur something?
Yeah. Dr. Ankur, it was an excellent presentation. And so I have one query. So you must have seen many cases of peridombal syndrome, and they present during the adolescent age, and they ask about plastic surgery. So what is your experience on that? Have you done any fat cell transplant for these patients?
Right. This is an excellent question. So, sir, this is something which we are now at a stage where we are asking our patients to go ahead and get these procedures done. Now, these procedures, so far we haven't done any of those procedures, but we are at a stage where these patients are now getting older, are above 18 years of age, and now we are planning to send them to plastic surgery and get these procedures done. So these can be done by plastic surgery. These can also be done by experienced dermatologists. So there are a lot of procedures like fat filler, which are done by these specialities. And this is something which is the treatment of choice in the chronic stage of many of these localized scleroderma. Once the disease is inactive and the patients are about 17, 18-year-old, we plan these procedures.
Any, do you have any patients with renal crisis?
No, sir. No, we haven't seen any patient of juvenile systemic scleroderma who has presented with renal crisis. No, adults, of course, they see, but not in children.
Okay, thank you. Okay.
I have a couple of quick questions.
Yeah, I was about to tell Dr. Neha is also here, and would Neha like to say something?
So
Yeah.
first of all, Dr. Ankur, very excellent presentation. You covered each and every aspect of systemic sclerosis, but I have a couple of quick questions. So a lot of times there is a very thin line of difference between MCTD and overlap. I really get confused when to label this patient as MCTD and when to label it as overlap. So a lot of discussion with adult colleagues, they usually say that if the course is severe and protracted, you don't label them as MCTD, you treat them as overlap. And there have been 2-3 such cases with ultimately ending up in mortality. Their course has been very severe. Every month they will have something, so it becomes really difficult to label them as MCTD. They will have very high U1-RNP positivity and features of combination of 2-3 rheumatological disorders. One is this, and second, when you were describing that case of primary Raynaud's and NFC changes, I remembered a few months back, I was seeing this case, this adolescent female. She presented with only Raynaud's and had digital tip ulcers that prompted me to go for NFC, and she had dropouts, but complete evaluation came back as negative. She is in follow-up. I started on nifedipine, but she keeps on asking me everything. When will I develop the disease? It's definitely not primary. I have told her it's secondary, but I cannot counsel her when will she develop that disease.
Right, ma'am.
Very difficult.
Yeah. So I will be happy to answer both questions, ma'am. So to your first question, I think this labeling is sometimes difficult for us as well. And then if we cannot fit into those criteria which have been proposed for MCTD, so there are 4 different criteria. The one that is commonly
Yeah,
used
and
is
which
then
one do you
Alarcon.
use?
So the criteria by, I think that Alarcon.
Yeah, the Russian one.
The Russian one. So that is the one that we commonly use. Now, it's not very, I find it not very important to fit into a classification, right? What we do is, okay, if we cannot classify them into anything, we just label them as overlap. But our management depends on the severity of the organ system involvement. Like if they have very severe renal involvement, for example, because of lupus, our management is entirely dependent on lupus nephritis. If they, for example, present with just arthritis, our management is predominantly based on management of arthritis. If they present with interstitial lung disease, our management is predominantly focused on interstitial lung disease. So I think from the management point of view, labeling is not so important. I mean, of course, it is important. From the publication point of view, yes, of course, labeling is important because you have to classify that patient as
That is
into
a
some of the
concern.
categories. So from that point of view, yes, it is extremely important. But many of these patients with overlap MCTD, it's very difficult to sometimes fit into any one of them, and we end up labeling a safer diagnosis of overlap syndrome in many of them instead. To your second question about this patient definitely has Raynaud's phenomenon, secondary Raynaud phenomena. If this patient has Raynaud's, if this patient has distal tip infarct, if this patient has Nailfold capillary abnormalities, this cannot be primary Raynaud's phenomena. This patient needs a long-term follow-up. This patient, would require an anti-nuclear antibody and a scleroderma specific blot. Now, some of the antibodies that we detect on scleroderma specific blot are not present in the normal immunoblot that we do commercially. So it is very important that we do a scleroderma specific blot if possible to assess which antibodies are present. Now, even if this is not possible to do, if the scleroderma specific blot is not possible to do, we know for sure this patient is going to evolve into something. This could evolve into skin tightness. This could evolve into interstitial lung disease, anything. But this patient is definitely likely to involve. This patient need at least now non-pharmacological measures, avoidance of cold, good vaccination, some of the non-pharmacological measures that we use for patient with systemic scleroderma.
You have such patients in your follow-up?
No, ma'am. So I think when they come to us, they are usually in a more advanced stage because of the issue with the this could be a referral bias. So we don't have any patient who has come to us with this kind of a presentation, who comes to us with Raynaud's, and we don't find anything underlying in that particular patient. So if they have secondary Raynaud's, we will end up finding something in that particular patient, and it would be easy to label them, whether it is scleroderma or lupus or dermatomyositis or anything other than this.
Thanks, Dr. Ankur. I
One
think
last
Dr.
question.
Shyam
We
has
have time.
raised his hand. Neha, just a minute. Dr. Shyam has raised his hand. Shyam, Dr. Shyam.
Yeah, good morning.
Good morning,
Thank you
Dr.
very much,
Shyam.
Dr. Ankur. Such a wonderful presentation. As a gastroenterologist, I want to add some minor things about your, as you presented already many things, that the GI manifestation in the multisystemic is quite common. As your literature says that the 30% patient have the dysphagia or GRD manifestation. But not only esophageal involvement, there are the multiple parts, segments of the GI involved in the sclerosis. Like the esophageal involvement is quite commonly picked up in the form of feeding difficulty, dysphagia. But that cases also have the some small intestine involvement, like the patient may be present at the pseudo-intestine obstruction like feature. Some cases have the large bowel involvement, can be present as a chronic constipation. But yeah, definitely, if we are the thinking involvement of the esophagus, so commonly lower segment is involved, but pen esophagus involvement is quite common. These cases are usually present initially as a features of like the GRD, intermittent vomiting, but subsequently when the disease is progress or evolve, that the presentation is more severe, like the significant vomiting, each and every feed, not only like the liquid, maybe solid or liquid both, along with child have the severe growth compromise. So I just want to highlight, don't depend on the clinical manifestation. If the child have the multi-systemic involvement and like the dermal or respiratory involvement, then you should take the child, call for the GI assessment. And manometry is one of the common entity. On basis of that, we can pick up the esophageal involvement in the early stage, where the pressure changes is quite common, because as available in the different series, this says like the GI involvement is 30 to 40%, but those are the series they consider as a upfront manometry study that the involvement is more than 50%, like the 70 to 80%. So I just want to highlight in front of house, those are the cases, not clinically GI involvement, but that child have the other systemic involvement can be considered for the esophageal manometry study. We can pick up early and start the treatment, because these are the child might be compromised nutrition. And usually for the management wise, definitely as a gastroenterologist, those are the children have the dysphagia significantly we give the dilatation of the esophagus along with your, as you advise, the definitive therapy like the steroid or a immunomodulator or biologics. On the child initially give the regular dilatation, subsequently that by the response of the therapy, the child responded very well. I have the experience recently in the last Friday, one child referred from the dermatology OPD to us. The child have the occasional vomiting. My gastro resident said the child have the intermittent system, not require any further investigation. Then I said, please consider for the manometry. The child has the significantly manometric changes, including lower esophageal pressure is quite low. So that provoked the for the GRD manifestation and dysphagia like that. So my request to all resident and clinician, those are the children have the multi-systemic involvement, kindly consider for the evaluation for the GI involvement. Thank you. Over to Dr. Ankit.
Sir, thank you so much, sir, for bringing this point. I completely agree with all the points that you mentioned. I think because of the time constraint, I think I underplayed the GI involvement part. If I had known that there is a gastroenterologist on board, I would have probably made significant spent some significant amount of time on GI involvement as well. But I completely agree with all the points that you have mentioned about esophageal and the other GI system involvement.
Thank you, sir.
Thank you, Dr. Shyam. Actually, when Ankur was speaking and Dr. Shyam is speaking, I remember one saying by a famous rheumatologist, do not label the patient, enable the patient. So, Ankur, anything? Ankur, you were saying something?
No, ma'am. No, ma'am. I'm not saying. I'm
Acha.
just. Yeah. Yes, ma'am. Mhm.
Dr. Shyam, you were saying something?
No, ma'am. No, ma'am. No, ma'am.
Acha. Okay. I think if there are no more questions, Ankur, an excellent presentation and a wonderful. I am really. Oh, Ajay sir is here. Ajay sir.
Yeah. So just wanted to thank Dr. Ankur and Dr. Neha and Dr. Anu for all these presentations, and thank you all the delegates for joining. And we'll be joining next week, next Sunday, same time.
So thank you everybody. See you next time, same time, 9 o'clock. Another interesting session. And this presentation is available for those who could not attend or had
Yes, sir.
attended partially, so that we can again revise the topic.
Yes,
Okay
sir.
then.
We would be sharing that. Yes, sir. Thank you. Thank you.
Thank
Bye
you
bye.
so
Thank you,
much.
Ankur.
Thank you so
Bye.
much, sir.
Thanks,
Thank you,
Ankur.
ma'am. Thank you, ma'am. Thank you,
Thank you,
everybody.
Ankur. Thank you so much.
Bye bye.
Bye.
Sir, ये desire में है.